I think there's going to be a lot to happen in the next 5 to 10 years in the world of stem cells. We have good studies that show that low hormones, whether this is women dealing with low estrogen, perimenopause, or low testosterone themselves, or men that are dealing with low or even borderline low testosterone. If it's low enough that it's giving them symptoms, there's an increased risk of heart disease. Replacement, that's a bigger deal. I mean, we can affect fertility, we can affect long-term endogenous testosterone production. So those decisions have to be made really seriously.
Welcome to the Peak Health Podcast, where we dive into practical science-based strategies to help you live longer, stronger, and better. Today, we're tackling a topic that's central to every man's vitality, but often misunderstood: testosterone and men's health. From low energy and decreased muscle mass to brain fog and libido changes, declining testosterone can quietly affect every area of life. But the good news is that it is fixable. I'm joined today by Dr. Steve Jones, a board-certified family physician and founder of Revive Longevity Center, who specializes in helping high-performing men over 40 restore their energy, focus, and strength through a personalized approach to hormone optimization, peptides, and lifestyle. Together, we'll unpack how testosterone really works, why it declines, and what you can do to reclaim your vitality and perform at your best for decades to come. Welcome, Steve.
Hey, thank you, Ravi. So glad to be here.
Yeah, it's great to have you. And I'm really excited about this conversation because I've been trying to find someone for some time to have this discussion. I was really pleased and happy that you were able to join and have the time to do so. So we'll go ahead and get started. Let's talk about some basics about you, how you got interested in longevity medicine and optimizing men's health.
Man, just like so many of us, Ravi, I got interested in it because of personal needs. I was starting to feel the symptoms of low energy, brain fog. Libido wasn't what I wanted it to be. I really enjoy working out, but I wasn't getting any gains at the gym. And so I started looking into all the things that have to do with almost being 50 years old. And this was maybe 4 or 5 years ago. Yeah, so it was really just selfishness, straight up selfishness that got me interested in it. But, once I got to rolling with it, this whole world of longevity medicine just unfolded before me. And it's fascinating and it's really helpful. It's helped me feel so much better. And then once you start seeing what it does for yourself, you just can't keep it a secret, right? You want to share that with other people as well.
Yeah, it's similar to the reason I got into it. I've always had this interest in longevity and functional medicine and optimizing health. But similar to you, as you get to a certain age, you're like, oh, hey, I'm starting to feel the changes. Like, what can I do to help myself? And then it expands and goes further. That's great. So, and we all focus on testosterone, and we're going to talk about testosterone mostly in this podcast. But is that the right place to focus? Is that the right hormone to focus on, or should we be thinking about other things?
Yeah, that's a great question, and we talked about this a little off air, Ravi. Like, longevity is a package deal, and I really feel like sex hormones are foundational. They're super important, but if you're going to try to fix everything with testosterone, eat like crap, drink heavy on the weekends, and not sleep good, have a high stress job, and not go to the gym, it's not going to work. So you've got to do all the other stuff if you really want to get the benefits of having optimized hormones.
Yeah, absolutely. Lifestyle is so important, and we'll talk about that. Before we do, just give me some general concepts surrounding testosterone deficiency, age-related decline, how fast it happens, things like that.
So we know that guys' testosterone will start to dip sometime in our 30s. It's at least going to level off. Once we hit 40, we're going to start seeing muscle mass loss. Some studies show 1% per year of muscle mass will drop off for men. And, from 40 to 50, that could be a tenth of your muscle mass. The loss of testosterone or the decline in production during that decade is a large part of that. There's probably just also some, changes in how active we are and how likely we are to go to the gym. So that there has to be some self-discipline in there as well. But that's kind of one of the big things. The other things that come up in this part of the conversation is, what is low testosterone? Are we going to go by what Blue Cross Blue Shield says and what they're going to pay for as far as lab and medication? Or what is optimal? because what is technically low is typically less than 300 on your blood test. But
Yeah.
not many guys feel good at 301.
Yeah.
We tend to start feeling better at about 600 in my experience. In some guys, they need to be up close to 1,000, maybe even into the low 1,000s to really feel optimal. And that also makes me think of, we probably ought to mention that there's some proteins in the bloodstream that
Sure.
bind to testosterone and they keep it from being active. And so some guys need to have a higher total testosterone level just so that there's enough active free testosterone to make them feel good and to get the benefits.
Yeah, so I'm glad, and we can just get right to it into lab testing because I think this is ultimately, one of the most important things to do if you're having symptoms of low testosterone, the things that we mentioned, brain fog, loss of muscle mass, loss of libido, decreased strength, then testosterone is something you should check. And I feel like men should check that at an earlier age. Like the standard is to check it when you're in your middle age, maybe, late middle age period. But really, when you're in your 30s, you should have a good understanding of what your baseline testosterone is, and then check these levels periodically. You mentioned total testosterone, free testosterone, and then the proteins like albumin and sex hormone binding globulin, I believe, are the ones you're talking about there.
Correct. Yes.
So how does the free testosterone and then the total testosterone play into this? Because those are the two of the main ways we check the testosterone
Yeah,
level.
you bet. So when the lab's doing that total testosterone, they're just checking every bit of it that's in your bloodstream circulating around. That number fluctuates during the day. I've done studies with friends where we'll like draw blood levels every couple of hours all day long.
Okay.
And we'll see that number range anywhere from like 400 to like 1,800.
Wow.
It's amazing how what we do during the day can make that level fluctuate. And then these are people that are untreated. We're just kind of curious. And, I've got friends that are willing to experiment with me like that. But whenever we're drawing blood work, I always like to tell guys to make sure they're doing it first thing in the morning, definitely not after 10 o'clock in the morning. So if we get a morning blood test, we're just more likely to catch the testosterone before the day and the activity level starts to make things change. But I like to check that total testosterone. And then I get the sex hormone bonding globulin and calculate my own free testosterone. A lot of labs will do that also,
Uh,
but every lab does it a little bit differently. And so I haven't found them to be completely reliable. So I have a little nomogram and a calculation that I go through that lets me determine what that number is. For members or listeners to the podcast, like I think it's perfectly fine if you just have your lab look at a total and a free testosterone and look at those normal value ranges. You want to probably be in the middle to upper tier of what that normal range would be. If you're in the lower half or getting close to that borderline low, you're probably going to be feeling it. Now,
okay.
a couple of other tests that I like to get are an FSH and an LH. Those are actually hormones that come from the pituitary gland, and they're produced based on how much hormones are circulating through the bloodstream. And those are the hormones that go from the pituitary gland, right? That's that little gland that's in the middle of our brain. And those hormones then go down to the testes to tell them to make more testosterone. There are some fellas that have plenty of ability for their testes to make testosterone, but they're just not getting enough of that signal from the brain, from the pituitary gland. And so testing for that also can help to decide what treatment might be best for some guys. So when we're looking at lab, I like the total and free testosterone. I always check a sex hormone binding globulin or SHBG. And then I like to get the FSH and the LH as well. And
Okay.
then the other thing that's just kind of my basic andropause blood panel, if you will, is an estradiol level. Just want to kind of see, where guys are sitting on the estrogen scale. That's something that typically isn't a big deal when you're getting the baseline levels, but it may be helpful to have that baseline when you start doing follow up after some treatment.
Okay.
Yeah.
And that's why you get the estradiol levels, just to see what the baseline is and see if it increases with treatment, because your testosterone could convert into estrogen as you're supplementing it, correct?
That's correct. Yeah. And there tend to be these guys, and we call them aromatizers, right? That's the medical lingo, but I'm seeing that even with a lot of patients. They've started to pick up on some of this terminology. So they wonder if they're an aromatizer. It tends to happen more so in guys that are overweight. So fat cells are going to be highly aromatizing cells in our body. And so I've had some guys that if you can really help them focus on weight loss, they can stop that conversion of testosterone to estrogen. And that works better than any aromatase inhibitor. If we can just get them into the gym, eating a really healthy diet, they start to get that lifestyle thing going for them. They lose some weight, they get more fit. All of a sudden, their testosterone is going higher and their estrogen is coming down. So a lot of this stuff can be fixed even without medication.
Yeah, and we're going to talk all about that in just a bit because that's super important. So just to round this out, what about thyroid levels, cortisol, DHEA? Do you check those as well?
Whenever I'm really just working strictly with the fella and in his testosterone level, I don't. Whenever I'm kind of doing more of a whole package, or if we're into treatment and really not getting any benefits, then I'll start digging into those others. There are a lot of overlapping symptoms, right, with thyroid disease and in high stress and really bad issues with circadian rhythm can screw up our cortisol cycle.
Right.
And so it's important to know what those things are doing as well. Totally agree.
Okay. And then what about prolactin? Do you check a prolactin?
I don't check a prolactin unless there's a history of any issue. Yeah.
Okay. So you got these baseline tests. I think, what we discussed is good is sort of a good framework for people to start with. Now, let's say, someone has low testosterone or they feel the symptoms that we described. Both you and I just spoke about lifestyle. Lifestyle is, in my mind, is, the number one, two, and three. Like, you really have to pursue these lifestyle changes
Mhm.
before you consider replacement therapy. Now, I think there's a role for concomitant use of both, and we can talk about that. But what are your thoughts on lifestyle and boosting testosterone?
Yeah, as most of us are going to go down that road first. Like we're going to start to really work on our diet, dial in our sleep, make sure that we're exercising, and then we're going to go down some supplement pathways, right? We're going to look at some zinc and maybe some ashwagandha, vitamin D. You probably know this functional medicine, supplement package off the top of your head pretty well. What
Yeah,
anything I'm leaving out there?
yeah, no, no, you're right. I mean, based on what you're saying, the right supplements. What I typically give people are, magnesium, omega-3 fatty acids, a good multivitamin. A good multivitamin should have zinc, other types of minerals like boron and things like that can help with bone health. And then vitamin D, I think I just mentioned, those are the important ones. Also, I, we talk about protein a lot. Protein is super important. People, and we can go off on a tangent on protein. It's a huge topic, but we'll just stick to the basics. If people don't get adequate protein, they are not going to build muscle, even if they're heavily resistance training. And that can be a problem, and that could cause a decrease in testosterone if you don't have proper um, muscle mass there. When you're lifting weights and things of that sort. So that's really important. So those are some of the supplements. What about just other things like you mentioned sleep and maybe alcohol use and things like that? How does that affect testosterone level?
Every cell in our body has a job to do. And if we can help those cells optimize their ability to perform, then obviously we're going to feel better and get and reap the benefits of it. And so there are so many things that we might do that hinder what a cell can do, right? It's like using alcohol or tobacco or not getting good sleep or having a fast food diet instead of trying to make sure we're getting, whole foods and a really like colorful, balanced diet. So there's some bad decisions that we can make that become obstacles then for the cells being healthy and doing their job. And when you think about the specific cells in the testes that are making testosterone, we want them to function well. So we want them to have the nutrients that they need, right? So that's the stuff that we just reviewed. If we're sleeping well and recovering well, then all the cells in our body do better. And so testosterone will be more likely to not be pushed down to a lower level because we're fatigued and cells aren't doing well. So nutrition, sleep, regular exercise is a big one. It's important that we exercise and that we're doing resistance training if we're trying to raise our own testosterone production, right? I think that makes sense to a lot of guys, but just to have heard it and, to heard it and it be said on this podcast, like it's so important that you exercise at least 5 days a week, and that at least 3 of those days you're doing resistance training if you're trying to boost your natural testosterone production.
If somebody presents to you, it requests testosterone replacement therapy or some kind of booster, and then you talk to them, you find out they're overweight, they're not exercising, they have the symptoms that we described, brain fog, weakness, loss of libido,
Mhm.
but they have motivation to change. They're saying they after you talk to them, they're like, hey, look, I'll exercise, I'll eat better. Do you pursue lifestyle changes, or do you say, hey, look, let's supplement and work on your lifestyle at the same time? How do you approach someone like that?
Yeah, most guys that come to me they've probably already started that stuff. I'm going to say probably 90% of guys that come to me with low T symptoms, they're already pretty aware that that's going to be an issue for them. And so most of them are already pretty highly motivated and have started that. If they haven't, that's the first place we're going to start. We're going to give it at least, a month or two just to do some of those initial basic things and see how they're feeling.
Right.
Personally, I started this pretty motivated. I already worked out, I already really was focused on taking care of my health in general. I was not taking all of the supplements that might help to raise my own endogenous testosterone. I did all of that stuff. It made no difference on my blood work, and it didn't really help me feel a whole lot better either. And that's probably been my experience with most guys. But mind you, most of the people that come to me are coming already pretty motivated. They've already gone down the rabbit hole a little bit, per se. And so that's the clientele that I work with. But the guys that haven't, that's absolutely where they should start. And they can work with somebody like you or myself to get that done. But so much of this information is readily available out there, right? It's like
Right.
you can get so much of this stuff for free, and then you can get the supplements going. I don't think anybody should have to spend hundreds and hundreds of dollars every month on supplements. They're pretty foundational what you need.
Yeah, Steve, I mean, that's a great point, because what I've seen out there as well is you have these certain providers that are these telehealth providers, and they will recommend supplements, peptides, testosterone replacement therapy, testosterone boosters straight off the bat. And that's how they get paid. I mean, they get paid by the subscription model. They want their clients to maintain this package, of supplements and hormones and such lifelong. And when you talk to them, because I had a patient recently that was on these therapeutics, and I was trying to speak to someone that prescribed them, and it was almost impossible to get in touch with anyone. And then he was able to get in touch with them, and they said, "No, just maintain it. Just don't think about stopping it." And that is the wrong thought process in my mind. I really feel like you should start with the things that we just mentioned, the foundational things, especially if you're motivated to do so and you haven't been doing so, and see how you do. Give yourself a couple months, see what your symptoms look like, recheck your levels, and maybe that's all you need. Maybe you don't need any more than that, but there are certainly people that do. And then we can go down that path in just a second. But what are your thoughts on that?
Yeah, I tell guys, look, I have so many dudes that are like in their 20s and early 30s that are coming to me. And I just tell them, tap on the brakes. Like, hopefully you've got decades to live and to worry about your testosterone. And
Right.
it shouldn't be something that you get so hyper focused on at an early age, you know, but so many guys do tend to kind of focus in on it. I'm not a big fan of jumping, especially straight to TRT. The booster stuff doesn't bother me as much because it's easily reversible. Like you stop taking a booster, things go back to baseline pretty quickly.
Okay.
No harm, no foul. But with replacement, that's a bigger deal. I mean, we can affect fertility, we can affect long-term endogenous testosterone production. So those decisions have to be made really seriously. Yeah,
Okay.
every day I tell guys that are wanting to go to TRT, like the replacement therapy, Bro, tap on the brakes. You're at such a young age. That's something that you're gonna probably have to do someday, but
Right.
there's no sense in rushing it.
Okay, interesting. So let's get to that. Let's talk about the let's maybe we start with the boosters. What are the use cases for the boosters and what are they?
Yeah, the booster that I use 99.9% of the time is enclomiphene.
Okay.
So it's similar to Clomid, which was an old fertility drug that we used in women patients. The generic of that is clomiphene. And then there's an offshoot of that medication called enclomiphene. And what it specifically does is triggers that gland in our brain, the pituitary gland, to make more luteinizing hormone and some extra FSH, follicle stimulating hormone. And so by telling the pituitary gland that there's not enough circulating hormones in the bloodstream, it makes that gland automatically produce more of that messenger hormone that then tells the testes to make more testosterone. And in the right person, I have found that treatment to be really, really effective. In fact, I'll often see testosterone levels double. That's sometimes too much. And so there are typically three doses that we'll use on that, like 6 milligrams, 12 milligrams, and 25. I tend to be pretty conservative with starting that treatment so that we can kind of start low and gradually build up as we need to, because sometimes you get some really robust responses by the pituitary gland and by the testicles when they get that extra stimulation to make your own testosterone.
That's interesting. So do you check an LH and FSH level prior to initiating this therapy? And do you find that you typically use it when people have lower LH and FSH levels?
The classic example is, some guy that's like 40 years old. He has all the symptoms of low T. His total testosterone is like, 450, but his LH and FSH are like 1.2. They're on the lower end.
Okay.
And then when we put them on enclomiphene and recheck their lab a month later, their testosterone is oftentimes almost doubled. So they're going to be up around 800 maybe. And then the LH and FSH are usually up significantly, maybe up around 4 or 5. Now, take that example and compare it to the 70-year-old that comes to see me. Typically, they may have a testosterone level. Let's say it's the same. Let's say it's like right around 400. They've got all the symptoms, but typically their LH and FSH are really high because their pituitary is recognizing that normal testicular testosterone production has really gotten low, and so it's putting out all the message it possibly can.
Okay.
So in that person, I pretty well know that like trying to boost more with enclomiphene isn't going to be helpful. So
Okay.
those are kind of the ways that LH and FSH number can help me.
Interesting. So it's really the differentiating primary versus secondary hypogonadism is what you're talking about.
Exactly. Yeah.
Okay. And just for the listeners, primary hypogonadism is when your testes aren't making the testosterone they should. Secondary is when your testes are actually functioning well, but the signaling isn't what it should be. And what is the primary reason for the decreased signaling or the decreased LH and FSH production? Is it stress related? Is it lifestyle related? What is that?
Yeah, so that is almost always a stress related thing. The people that I see that most commonly in are young executives. People that are just really working super hard. They've got big sales jobs. They've got leadership positions in their companies. They don't sleep well. Their lifestyle is typically a mess, Ravi, and
Yeah.
but they're working hard. They just their body is so fatigued that it can't send those signals the way it needs to. Another group from a different angle fits that same bill is in our veterans. I see a lot of men who have had previous service. They suffer with PTSD. And then I've noticed that those guys tend to have that secondary hypogonadism as well.
Okay.
Yeah.
And then what about HCG? Do you use that with enclomiphene or is that not something that you use typically?
Yeah, to me, it's either or. You're going to get the same effect. So HCG, human chorionic gonadotropin, acts just like luteinizing hormone does. It's kind of the same molecule. So whenever you're doing an HCG injection, you're just giving your body a stimulus that's going to make your testes make more testosterone. And what we're doing with enclomiphene is taking a tablet that tells the pituitary gland to make more of that hormone already. So I never use the two in combination. It's kind of
Okay.
like one or the other. Yeah.
One or the other. Oh, I see.
Yeah.
Okay. Are those the boosting agents that we typically hear about, are the ones you use, or are there other ones that we haven't discussed?
Yeah. Those are the boosting agents that you hear about.
Okay.
Yeah.
So if you have a case where the LH and FSH are normal, the testosterone is low, so now this is primary hypogonadism, that's a case where you think about using testosterone replacement therapy, correct?
That's correct.
What's the thought process in using testosterone replacement therapy? You mentioned some side effects and concerns. Maybe you can just talk a little bit about that.
Yeah. When we're doing TRT, the first thing I want to talk to guys about is how old are they? Are they thinking about fathering children? We always have to keep in the back of our mind that replacing testosterone reduces the normal function of the testes. Eventually, the testes are going to stop making testosterone. And when they do that, there's going to slow overall function in the testes. Their other big job is to make sperm. And so if they're not making sperm, that can lead to infertility. And so I always caution guys, especially in their 20s and 30s, that may want to have children, put off doing TRT until you've done that. Enclomiphene is probably going to be that those booster agents are probably going to be a much better fit until you get to the point that you're not ready or no longer wanting to have children or to father children. So
Okay.
that's the first thing. Yeah.
So that is the one of the biggest concerns is are your focus on having a family, having kids or not?
Yeah.
Um,
I think that's the first concern. Yeah.
okay. What are some other side effects, concerns about testosterone replacement therapy?
The next conversation I'll have with them is like, okay, if you're going to start this, you need to think about this as a forever treatment. Because I have had a few patients who were on TRT in the past, and then they stopped it for whatever reason. They were tired of doing shots. It got too expensive for whatever reason. Then they come in and their testes never quote woke back up and never started making a good healthy production of testosterone once they stopped the replacement therapy. And so they were stuck. If they were ever going to feel good and have normal testosterone levels again, they were going to have to take it. And so that's part of the reason why I caution guys about starting too soon. I always want to make sure that they recognize that the benefits of doing TRT need to outweigh that one risk.
Now, is that true for just physiologic replacement doses, even of testosterone? You could suppress,
Yeah.
permanently suppress testosterone production,
Yes.
or endogenous production, that is.
Yeah. And I've seen it. It's not just with the bodybuilders that are doing, the big anabolic steroids. I've seen it with guys that are just doing regular old testosterone shots from their local doctor. And
Okay.
yeah, it's not super common, but it's one of those things that can happen. You just need to be aware.
So, enclomiphene, you're not going to see those. You're not. You're going to have those concerns or side effects with that. What are the? We didn't talk about the side effects of enclomiphene. What are they?
I prescribe a lot of enclomiphene, and I rarely see side effects from it. The ones that we're going to, if anything, might be a little bit of fluid retention. That is one that I'll see from time to time. Sometimes there's a hypersensitivity in the nipples, which is kind of an unusual. I don't really understand what happens, but that's probably the number two most common side effect that I see. Gynecomastia rarely ever happens because enclomiphene is actually an estrogen receptor blocker. It's a SERM, so you're not going to typically see those high estrogen side effects that you'll see with testosterone. Enclomiphene to me is a really great entry level type of low T or borderline T treatment because it does tend to be forgiving. It is very easy to stop and just let things go back to their previous baseline. And then the side effect profile is really, really low. I treat a lot of people with enclomiphene, and it's pretty rare that I have a true side effect from it.
Okay, interesting. Another question along those lines: if someone, let's say, has normal testosterone
Mhm.
and just wants to improve their physique, build more muscle, lose fat, they just want super physiologic doses potentially, and they want to take enclomiphene off label or testosterone replacement therapy off label. Like, How do you manage those types of folks?
So that's going to be a very personal like that. That's a lot of doctor and client back and forth in talking through that. I'm not inclined to approach super physiologic levels. And in my book, that's going to be a free testosterone that goes past 250. I don't mind it being in the ballpark, but so some guys are going to come to me and their free testosterone, just right out of the gate is like 240. And I'm like, no way. You already have so much.
Yeah.
It's like there's not going to be a benefit. It's just only going to be asking for, even though they're rare side effects, why mess with it?
Yeah.
Yeah.
I don't know if you're familiar with this guy, Mike Israel. He's one of these YouTubers. I follow him. He's an interesting guy. He has his own thoughts on testosterone replacement therapy. He takes he's a PhD in sports physiology.
Okay.
Talks about all this kind of stuff in his podcast, but he takes super physiologic doses of testosterone. And what he says is that he says, I know I'm risking fertility. I know I may not have kids, but his biggest focus is his aesthetic and the amount of muscle he can build. And he says, for that reason, I'm taking this. But then you think about all the potential side effects of very high doses of testosterone. In my understanding, there could be some, you could have some cardiovascular issues with that as well. Is that correct? I may be misremembering, but
Yeah, I think that's absolutely correct.
right.
To me, there's a tipping point.
Yeah.
And we have good studies that showed that low hormones, whether this is women dealing with low estrogen, perimenopause, or low testosterone themselves, or men that are dealing with low or even borderline low testosterone. If it's low enough that it's giving them symptoms, there's an increased risk of heart disease.
Yeah. Okay.
And we can actually lower that risk if we do physiologic levels. I love it that you used that term earlier. That's what I focus on. I don't see any data that says that we're helped, especially from a longevity perspective. And that's my focus and my goal for my clients is longevity, which means that we're going to feel better and have fewer chronic diseases as the decades go by. And so if that's our focus and our goal, then physiologic levels do tend to get us there. Low levels are going to raise the risk. And there's also great to your cardiologist. That's when they're going to say, yeah, these guys come in and they're having heart attacks. No scare tactics here. I know that there are ways to get around that. I know you can do phlebotomies. I know patients that do. So patients with physiologic levels on replacement, they do really, really well. It lowers the risk of so many diseases, including heart disease. Higher levels, though, when you push the envelope, you get a higher blood viscosity. You may have to go do some blood donations or blood draws. We call them phlebotomies, where we're taking blood off to lower the red blood cell count. Those are the situations that start to induce risk of heart disease.
I see.
As a longevity doctor, obviously, we don't want to do that. We want to keep people right in the middle where we know things are going to be healthier for the long haul.
So that's the reason to check these serial labs. And how often do you check them? Every 3 months or so, or 6 months? How often do you check them when they're on these therapies?
If they're on enclomiphene and they're doing really, really good, I go every 6 months.
Okay.
I think it's reasonable to check it once a year on somebody that's, in their 40s and otherwise healthy and things are going great and you've got a couple of blood tests and some guys are a little reluctant to want to do all the blood work, and I get it.
Right.
I really don't have any concern about that. Guys that are on TRT, I'm more like maximum 4 months, maybe 6 months if the dose has been steady for a long time.
And what you're checking, just to review once again, you just mentioned hemoglobin hematocrit to make sure that those levels don't go up too high. You're checking obviously their free testosterone, their total testosterone, estradiol levels,
Right.
LHFSH.
Mm-hmm.
Those are the ones that you're following. Do you follow prolactin with those patients? You don't have to follow it. And my understanding is there's no risk of prostate cancer with
Correct.
testosterone replacement therapy. Is that correct?
Correct. That is correct.
Okay.
We know that TRT doesn't increase the risk. I've even got a few select patients that have developed prostate cancer while on treatment. Obviously, they have to come off while they're being treated. They feel so bad, but after treatment and after they've had successful treatment, their urologists are now willing to selectively they'll write me a letter saying, I think this guy's doing great. If you want to go back to treatment with TRT, you can. I've got two patients in my panel now where we're doing that. It doesn't happen on every case, and it doesn't happen with every urologist. But that does give a lot more confidence to know that even in the people that are treating prostate cancer cases actively every day, that there's a recognition that high testosterone is not the culprit for that.
Interesting.
Yeah. It,
Great.
it can complicate things when they're getting treatment. And so we always stop it during that time, though.
Okay. Okay, got it. That's fascinating stuff. So, I think that's a nice overview of, testosterone boosting and replacement therapy. Unless there's something that I've forgotten to ask or you want to talk about, and then we can maybe talk about peptides.
Oh my gosh, peptides. Yeah, we better save some time. So, yeah.
Right. Right. I mean, it's a very big topic, a lot to talk about in one podcast. In fact, we could probably spend, many, many podcasts talking about peptides, but I do want to discuss this topic because I think, when nowadays, especially when people talk about testosterone replacement therapy, testosterone boosting agents, they often hear peptides as well as part of that, overall formulary for men's health. So can you just give me just a general overview of, what peptides are and how they can be helpful?
So peptides are these short chains of amino acids. They're so short they're not even long enough to be called a protein. And they have a function in the body. The peptides that we use on humans are actually identical or identical enough to the peptides that are naturally made in the body that it's almost uncanny. And there are thousands and thousands of identified peptides in our body. One of the most common that people hear about these days is BPC 157. And I think it just kind of makes a good example of an explanation for what a peptide is and how they work. So BPC 157 is a peptide that's made as a synthetic in a laboratory that's identical to a peptide called body protection compound that's made in the foregut. So kind of right at the bottom of the stomach in the first portion of the small intestine. That peptide then gets into the bloodstream. Part of it goes down through the intestine. It helps to lower the chances of stomach ulcers, of inflammation in the colon. The peptide that gets absorbed into the wall of the small intestine and gets in the bloodstream then can help with inflammation and can help with repair of soft tissue like muscle strains, sprained ligaments and tendons, even torn ligaments and tendons. Tissue wounds like if you got a laceration or if you had a surgery and you're trying to heal up a wound, that peptide helps with all of those things. And so what the scientists have learned years ago is that you can take these small little chains of amino acid that are already naturally made by the body and give a little extra injection of them selectively to try to help a particular problem or to get a specific benefit. And you stimulate a natural pathway in the body. So you're not taking anything over. It's almost like you're just kind of opening the floodgates where a little bit more of what normally happens to a positive benefit can happen just a little bit more for a specific reason.
Interesting. Okay. So you're sort of modulating your own intrinsic physiology with these peptides. You're pushing things in a direction that they're typically already going, but maybe not. You're pushing more than, the physiologic standard.
That's right. With the recognition, and this is a little bit deeper, Ravi, but just for you and I, that all of these mechanisms have feedback negative effects. And so we're typically pushing down a hormone pathway that causes good things to happen. But obviously, if you push too hard for too long, it may turn bad. Well, there's negative feedback loops in these systems that then turn off the pathway from happening. So if you even go too hard for too long, those things tend to be downregulated. So there's almost like a little built-in safety factor. I don't want to overstate that because there have been examples where people can go too hard for too long and have problems. But by and large, that can be a difficult thing to do.
Absolutely. Okay. And now, there's so many peptides. There's like hundreds and hundreds of peptides, and I know there's no way we can talk about them exhaustively, but I'm sure there are a few that you really like, and
Mhm.
maybe you prescribe to patients along with, these other therapies that we mentioned. Can you just discuss those?
You bet. So, probably the most common ones are the BPC 157, which I've mentioned, and the other ones are the human growth hormone secretagogue. So the class of peptides that make our pituitary gland again make more growth hormone for us. So those are like testosterone, ipamorelin, sermorelin. Those are the most common ones that I've seen patients interested in, and the ones that I've used most commonly. They help to release a little bit more human growth hormone when we're sleeping at night. That leads to a little bit better sleep. Better stage 4 sleep leads to better recovery, better clearance of like all of the extra fluids in the brain. Remember the lymphatic system from medical school? Like
Yeah.
all of that stuff happens in the first half of sleep, and we're in deep sleep or stage 4 sleep. And so growth hormone is responsible for a lot of that. That leads to better recovery. That leads to waking up feeling better, feeling less brain fog, having more energy, which leads to a better workout that afternoon. Hopefully, if you're taking this stuff, then you're trying to really get a maximum benefit. You're going to the gym and working out. That leads to better recovery so that you can work out harder. Better recovery with a harder workout means you get more muscle gains. So they tie in so well with a testosterone protocol that you can really start to maximize one with the other.
Oh, that's really interesting. And what are the downsides of taking these types of, let's BBC 157 and then the growth hormone releasing peptides? Like what are the downsides?
Yeah, if you take them for too long, since there's short chains of amino acids, the immune system is going to start recognizing them. And it's possible that you're going to start making some antibodies to them. So we will see some people start to get some, just like where they gave the injection, they'll get a little site reaction that gets itchy. That can turn into a full-blown allergy. So you'll often see doctors wanting to just do like maybe an 8 or 12 week maximum on one particular peptide at a time, just so the body isn't always being exposed to it and it'll calm back down.
So you cycle them every like 12 weeks on, or 8 to 12 weeks on, and then 4 weeks off, or how?
Typically, we'll go 4 weeks off. And what I'll do with my clients is rotate them to something else. From the longevity studies, we know that there's a pathway where our body does our catabolic stuff, like we're building muscle, we're synthesizing protein, like everything's like running a little hotter. And that's like where the growth hormone stuff might come in so that you can build muscle and get some good stuff going. And then there's that other pathway, right? That AMPK where we're resting and recovering, and that's where longevity starts to happen. And so there are different peptides that can be helpful then. I like to use BPC in that off cycle so that we can help to, repair any strained muscle, or if there's a little bit of back pain or a nagging shoulder thing from doing too many chin ups,
Yeah.
we can start to heal up some of those things while we're not pushing so hard to build muscle and synthesize proteins as much. That makes
And
sense?
yeah, so you do that. Do you do that for 4 weeks when they're off cycling the growth hormone
At least four
peptides?
weeks, yeah,
Okay.
and sometimes more like 8 to 12.
Okay.
Yeah.
So then you're crossing them with, so they're taking the BPC 157 plus the testosterone, sermorelin for 4 week overlap period, and then they're off. So they're sort of like consistently cycling them.
Consistently cycling, that's right.
Okay.
And we'll work with clients if you've got a 10K race coming, or a Tough Mudder, or a CrossFit competition.
Yeah.
We're going to try to push and build up until competition or race day. And then afterwards, we're going to back off of push, and we're going to come back in and help to repair, recover. There's some peptides that help mitochondria turn over, so you've got, healthier mitochondria. We'll use those kind of varying on and off again in somebody's training leading up to competition or race day, and then in recovery afterwards.
What peptide is that?
There are a couple of them. One is MOTS-C, MOTS-C, and the other one is epitalon.
I see. And those are recovery peptides.
Yeah.
Got it. And how often do you prescribe these peptides along with the testosterone boosters or replacement therapy?
It's very common.
Okay.
Off the top of my head, I have to think for a while to give you a percentage. They get expensive. That's probably the biggest limiting factor to them, is that
Right.
these things can get pricey when you start stacking them. I think if the price starts to come down on these with more production, as long as we can maintain really high quality and control, which is a like a whole nother podcast episode on its own.
Yeah.
Um, yeah, I think it's probably going to be ubiquitous. I think everybody is going to end up wanting to try a combination of something to help testosterone and a course of peptides to optimize how they're performing, how they're functioning, how they're recovering, how they're aging.
These are all subcutaneous injections, correct?
They are, yes. There are a few that can be taken sublingually or even orally, but we always see better results when we do subcutaneous shots. Yeah.
Excellent. Okay. The other question, I mean, you sort of brought this up in terms of like availability. Um, a lot of these compounds are not FDA approved, or they are being pulled from compounding pharmacies and things of that sort. How do you find a supplier to give high quality substances? Like where do you get that?
Yeah, it's not easy. And I found two that I am pretty much committed to using because it took a while, but once I found them and was able to meet some of the scientists that are at the labs where these are being created, I started to get some confidence in them. There are also places where I know other longevity doctors are getting their peptides, getting good results. If you're going to work with a provider, I would just tell your listeners to make sure that they have access to like third party testing on purity and contamination. Like we want at least 98%, preferably 99% pure. And then you want to make sure there's no endotoxins and different bad things inside the peptides. That's something that you should make sure that you're able to see. The places that I use, it actually has a QR code on each vial where you can scan it and look at that report for that specific lot. That makes me feel better. But really, the more important thing is just my experience with them. I've used them for almost a year now with really good results, and knock on wood, no bad outcomes. And so confidence grows with time.
That's excellent.
Yeah.
Yeah, and the side effects are pretty limited for these peptides, at least the ones that you mentioned, correct?
Side reactions is by far the most common one. Some people can be sensitive to the positive benefits. In fact, I had a client I was working with last week who one of these growth hormone secretagogues was making their heart race a little bit. And it can happen. So we had to cut the dose in half after taking like a 4 day break from the medication. So some people can be sensitive. These are real things. They have a significant physiologic impact on the body. Every body is different, and so you have to listen to your body. If you feel something like that happen, make sure you report that back to your doctor so that they can make some adjustments.
Do you check IGF levels when you're prior to prescribing or during prescribing these growth hormone analogs, or no?
I don't. And the places where I've seen that done and where I've talked to providers that do it, they never see the IGF level change. And so I
Interesting.
think it's because of that negative feedback mechanism, especially specifically with the HGH secretagogues. If it starts to run a little bit high, the pituitary gland gets that negative feedback and just kind of dials things down. So I think you probably have to do some pretty like sophisticated, timely IGF-1 testing. I've never found that to be beneficial.
Okay, great. This was awesome, Steve. I mean, your insights are really profound here, and I'm sure our listeners got a ton out of it. I'm just want to go through some quick closing questions. What
Okay.
what would you say excites you most about longevity medicine right now?
Oh my gosh. Man, this is completely off subject, but I think there's going to be a lot to happen in the next 5 to 10 years in the world of stem cells. But we're learning so much about exosomes. There are newer ways to harvest into in a very safe and humane way, and without running any risk of being too edgy out there. Ways to get good quality stem cells and then do some really amazing things with them. It's going to be a slow evolution probably, but I'm probably most excited about that. I have some secondary gain in that though, Ravi. My daughter is a type 1 diabetic. She was diagnosed at age 10. She's now, mid 20s and expecting my first grandchild. And so I would love to see, something come from that that could help type 1 diabetics get a cure that they so desperately need. And I
Yeah.
think that those kind of things in the world of longevity are coming. Right now, we're using a lot of those products for aesthetics, for collagen synthesis in the skin to stop wrinkles and lines very effectively. But I think there's going to be a huge application for those down the road. I'm hopeful for it. We'll see what happens.
Yeah, well, that does sound exciting. Another quick question. What, if you could choose one peptide, what should every man consider trying at some point? One peptide.
If I had to pick one to cover all the bases and just to maybe take it for 8 or 12 weeks and then take a month or two off and cycle back on it, I'd probably pick KPV. It's just three capital letters, KPV. It kind of covers all the bases. It's a you have to go read about it. It's a pretty remarkable peptide, but you get some longevity benefits. You also get some catabolic benefits from it. So that might be the one I would pick. But ask me tomorrow, and I might pick something different.
Okay. I thought you were going to choose BPC 157, or I hear that one a lot. Um, but
It's
it's interesting.
it has
KVV
it is
I haven't heard of.
Yeah, BPC 157 has been one of my most effective peptides. It fixed a couple of shoulder issues that I've had, and been very happy with it.
That's really interesting. Well, Steve, this was amazing. If someone wants to learn more about you and maybe more about the Revive Longevity Center, how can they do so?
I think if you just Google Revive Longevity Center, type in there Dr. Jones, I think you'll find me. We're on Facebook, Instagram. My nurses even have a TikTok up and going where they put some funny stuff out that kind of keeps a little bit of a humorous edge on longevity. So I think you could probably find me in those places. And thanks for asking.
Absolutely. Thank you so much, Steve.
You bet, man. Thank you for having me.